So welcome back to part 4 of our hypoglycemia series. In this section, we'll explore how common hypoglycemia is in diabetes and its wide-ranging clinical impact. So in type 1 diabetes, hypoglycemia is a frequent and often recurrent complication with severe episodes affecting up to 40% of patients annually. In type 2 DM, hypoglycemia is less prevalent in early stages but becomes increasingly common with the use of insulin as well as SU, particularly among older adults. The real-world studies confirm that symptomatic hypoglycemia remain a significant burden in insulin-treated type 2 diabetes, underscoring the need for individualized therapy and proactive risk mitigation. The hypoglycemia frequency and predictors in insulin-treated diabetes. As you can see in this slide, the study confirms that hypoglycemia is common in both type 1 and insulin-treated type 2 diabetes. On average, type 1 patients experience about 3 to 4 mild episodes per month and nearly 1 severe episode. Type 2 diabetes patients had fewer events but still face meaningful risks. Predictors includes lower HbA1c, longer insulin use, younger age, and a history of previous hypoglycemia. These findings highlight the need for personalized glycemic target and proactive risk screening to prevent recurrent episodes and protect patient safety. Now, way back in 2004, a large multi-center study conducted across Denmark and the UK examined 1,076 adult patients in type 1 diabetes. The researchers found that severe hypoglycemia was frequent and often recurrent. Risk was highest in those with longer diabetes duration, a history of previous severe episodes, tight glycemic control, and impaired awareness of hypoglycemia. Now, this landmark study emphasized that severe hypoglycemia is not rare. It is a major clinical challenge. Identifying high-risk patients and tailoring treatment strategies remain essential to reduce recurrence and improve safety. And more recent studies show that hypoglycemia remains a major burden in both type 1 and insulin-treated type 2 diabetes. A 2023 meta-analysis found about 1 severe episode per patient per year in type 1 and lower but still significant rates in type 2. Even with modern technology using CGM to monitor blood glucose, a 2024 survey showed that severe hypoglycemia and impaired awareness persist. And the real-world data confirm that up to 40% of insulin-treated type 2 patients experience hypoglycemia. These findings highlight the need for prevention, education, and individualized care. Now, acute hypoglycemia exerts multi-system effects that compromise patient safety and functional capacity. Neuroglycopenia leads to cognitive dysfunction, mood alterations, and impaired psychomotor performance, reducing work efficiency, driving ability, and daily functioning. In central nervous system involvement may escalate to seizure, coma, and psychological distress. Musculoskeletal consequences include falls, fractures, and trauma-related morbidity, and particularly in older adults. Cardiovascular risk encompasses myocardial ischemia, arrhythmias, and potential heart failure driven by adrenergic surge and hemodynamic instability. These short-term impacts underscore the urgency of early detection, patient education, and individualized glycemic targets to mitigate them. Recurrent hypoglycemia imposes significant long-term burdens on patients with diabetes. It contributes to diminished quality of life, driven by persistent fear, reduced confidence in self-management, and poor adherence to treatment regimens. Functional limitation may arise, including restrictions in employment and driving licensure, which impact autonomy and social participation. Personal relationship can be strained by unpredictability and emotional toll of recurrent episodes. Over time, cognitive decline may develop, particularly in older adults or those with frequent severe events. Importantly, chronic syndromes such as impaired hypoglycemia awareness and counter-regulatory hormone deficiencies emerge, further increasing vulnerability to future episodes. These long-term sequelae underscore the necessity of individualized glycemic target, structured education, and proactive risk mitigation strategies. Now, this study examined severe hypoglycemia and cognitive function in 718 older adults in type 1 diabetes. This is from the solid cohort. Participants reported recent and lifetime severe hypoglycemia requiring hospital or emergency care, and cognition was assessed globally and across domains. Analysis showed that both recent and lifetime severe hypoglycemia were linked to poorer cognition, with recent severe hypoglycemia especially tied to impaired global function. These findings highlight the harmful impact of severe hypoglycemia on brain health in older adults and the importance of prevention. Now, this diagram illustrates striking reality. Patients with diabetes often rank their fear of severe hypoglycemia as high or even higher than their fear for long-term complications like blindness or kidney failure. Based on this finding from Praming and colleagues, this emotional burden is especially pronounced among women who consistently report greater worry across all categories. The fear of hypoglycemia, whether mild or severe, can rival concerns about irreversible organ damage, reflecting its immediate danger and disruptive impact on daily life. These anxieties also extend to broader psychological stress, including persistent thoughts about diabetes and its consequences. Clinically, this underscored the need for empathic care, tailored education, and safer treatment strategies that address both physical risk and emotional well-being. The diagram highlights the significant financial burden associated with confirmed hypoglycemia in diabetes care, as reported by Williams et al. In the Journal of Diabetes Complications. Patients with documented hypoglycemia consistently incur higher annual costs across all categories: hospital visits, pharmacy expenses, and diabetes-specific care. Compared to those without hypoglycemia, their total healthcare costs are markedly elevated, with statistically significant increases in diabetes-related and pharmacy expenditure. This finding underscores that hypoglycemia is not only a clinical emergency but also a costly complication that strains both patients and healthcare system. Preventing hypoglycemia is essential not just for safety and quality of life but for reducing avoidable resource utilization and economic impact. Now, hypoglycemia poses serious health risks even at mild to moderate levels, with potential link to stroke, heart attack, heart failure, and as well as arrhythmias. When severe, it can lead to seizure, coma, and death. These findings emphasize the hypoglycemia is not a minor issue but a dangerous complication requiring close monitoring, personalized care, and proactive prevention to safeguard cardiovascular and neurological health. So this comparative chart from the ACCORD and ADVANCE trials revealed a sobering link between hypoglycemia and mortality in patients with type 2 diabetes. In both studies, these are two studies of DM outcome studies, individuals who experienced one or more hypoglycemic events had significantly higher annual death rates than those who did not. regardless of whether they were in intensive or standard treatment arm. For example, in the ACCORD trial, mortality rose from 1.3% to 2.4% in the intensive group and from 2.8 to 4.9% in the standard group when hypoglycemia occurred. In advanced trials showed similar trend with mortality doubling or more among those with hypoglycemia. These findings challenge the assumption that tighter glucose control is always safer and underscore the need for individualized target, careful monitoring, and strategies that minimize hypoglycemia risk while preserving long-term outcome. The pathophysiologic cardiovascular consequences of hypoglycemia. Studies have shown that hypoglycemia triggers multiple harmful cardiovascular responses. It increases inflammation, disrupts blood clotting, impairs blood vessel function, and activates the sympathoadrenal system, leading to rhythm disturbances, elevated heart workload, and oxygen demand. These changes show that hypoglycemia is a serious cardiovascular stressor, not just a metabolic event. Now, these charts illustrate the dual burden of hypoglycemia, its physiological disruption, and its psychological toll. On the physiological side, falling glucose levels trigger counter-regulatory hormones like glucagon and epinephrine, suppress insulin secretion, and impair brain function. Now, patient may experience irritability, confusion, drowsiness, and even prodromal symptoms like lip numbness or scalp tingling. But beyond the physical, the psychological consequences are equally impactful. Fear of hypoglycemia can lead patients to maintain higher than optimal glucose level, skip nighttime insulin, avoid exercise, or resist being alone. This anxiety may elevate A1C as much as hypoglycemia, itself creating a cycle of avoidance and suboptimal control. This insight highlights the need for holistic care addressing both metabolic and emotional dimension of diabetes management. Now, this slide highlights the hidden danger of nocturnal hypoglycemia. Now, over 70% of hypoglycemic episodes occur during sleep when symptoms often go unnoticed, unrecognized, or unreported. These silent episodes are linked to serious outcomes including unexplained cardiac arrhythmias and the rare but fatal dead-in-bed syndrome. Warning signs may include confusion, irritability, sweating, nightmares, or waking up unusually tired, clues that often escape attention because these events happen when patients are least aware. Nocturnal hypoglycemia represents a critical challenge in diabetes care, demanding proactive monitoring, tailored therapy, and patient education to ensure safety overnight. Now, severe hypoglycemia drives higher emergency hospital utilization. Now, among U.S. adults in diabetes, those who experience severe hypoglycemia have over 5 times more emergency hospital visits, 6.8 versus 1.2 per 1,000 person annually, compared to those without. This highlights the urgent need for safer therapies and proactive prevention strategies. The hypoglycemia-related emergency visit rise sharply with age and comorbidity burden. Older adults face the highest risk, and each hospitalization carries substantial costs. This event collectively impose a significant financial and clinical burden on healthcare system. The study rate of hypoglycemia and hyperglycemic emergency among U.S. adults with diabetes 2011 to 2020 published in Diabetes Care. This analyzed national trend in acute glycemic event from 2011 to 2020. Hypoglycemia related emergency showed a modest decline, yet they remain consistently higher than hyperglycemia related emergency visit. In contrast, hyperglycemia related emergency particularly diabetic ketoacidosis, rose especially among younger adults. Both conditions continue to drive hospital utilization, underscoring the need for safer therapies, patient education, as well as improved access to diabetes care. Now, frequent hypoglycemia significantly raises healthcare costs as each episode can amount to thousands in hospital, emergency, and indirect expenses. For patients with repeated events, yearly costs may climb to $25,000, underscoring the urgent need for prevention and safer treatment approaches to reduce both clinical risk and economic burden. So the cause of hypoglycemia on both clinical and societal dimension, that frequent hypoglycemia impairs cognition, destabilizes the heart, and increases fall risk. It erodes quality of life, drives fear that comprises glycemic control, and imposes a measurable burden on healthcare system. So in summary, hypoglycemia is common in type 1 diabetes and insulin-treated type 2 diabetes with wide-ranging consequences. It impairs cognition, increases cardiac and safety risks, and contributes to psychological distress that undermines glycemic control. At the system level, it drives emergency visits, hospitalization, lost productivity, and substantial healthcare costs, making prevention a clinical and economic imperative. With that, I conclude our part 4 of Hypoglycemia series. Up next is management and prevention of hypoglycemia.